Also, it gives me a great pleasure to introduce Professor Hany Eteiba, a consultant interventional cardiologist from Glasgow University in the UK, who's also joining us for the first time in our meeting. I'd like to welcome you, Dr. Hany, and his talk is a complex left main PCI, the tough decision making.
Thank you very much indeed for the organizing committees and for the audience for staying here for the last day. Great pleasure to be with everyone here. And really, I'm going to go back home, delighted to see old friends, Hany, Ragi, Andrea, Mohammed Subhi, Antonio, and everybody here. But also, I will go warmer and richer by the relationship and partnership with new friends from the Gulf International Interventional Society. Thank you, and we are very proud and privileged to be here with you today. And really what I'm going to do here is we've heard an amazing tour de force from Antonio about the history and from Andrea about the evidence. I'm going to try to put both together and give you the flavor and how difficult it is and challenging to apply evidence in daily practice. And this is where the wisdom, the experience comes, and the teamwork comes to the equation. So it would be absolutely unfair of me to be in the Middle East and not recognize that you are the land of medicine. The golden age of medicine started here. These are just few of many scholars and great guys that really showed the world what to do. Al-Razi, depicted here, taking the pulse and making urine analysis. Avicenna with the Qanun al-Tib, or the Qanun of medicine, and Ibn al-Nafis with all what we know about him from discovering the pulmonary circulation. And to those people, we stand humble and we recognize and we appreciate all the efforts that they have made for us. But also following their footsteps, there are equally dedicated people here in this room who will continue and will bring the future back. So we're here to be back to the future in this part of the world, and thanks to every one of them here. But also a gentle reminder is one of my favorite quotes, is that if you want to go fast, go alone. If you want to go far, go together. And here being together, we will even go further in the future, and I wish you, the Gulf Interventional Society and the entire Middle East, our very best wishes for more progress and further development. Now I'm here talking on behalf of team. This is the Golden Jubilee National Hospital where I work, and it's an entire team. It's a multi-professional, multidisciplinary. It's not all to do with the leader or me as part of that. I'm proud to show this slide because in the United Kingdom, the Golden Jubilee National Hospital has been the highest volume of PCI in the entire country for the last few years, even during the COVID pandemic, and there are a lot of reasons for that. We're talking about left main challenges, and still the guidelines gives the absolute superiority for bypass surgery, particularly in complex lesion, and it's almost merging on no PCI should be considered, but we'll see what that is like. In simple lesion, they are both equivalent, and angioplasty is an important role to play, and it can be an alternative to surgery in moderate complexity lesion. But the reality is that is in stable conditions. Nonetheless, we practice now virtually 70% plus of our patients are coming with acute coronary syndrome, and the rest are elective. Elective is becoming the minority. So angioplasty to left main, I don't want to elaborate the point, but wherever you are in the presentation, stable, STEMI or non-STEMI, and over the last 5 years, we are dealing predominantly with just under 5% of our practice is left main stem. So the most important thing is the decision making and the guidelines versus the real life practice. At times, decision to perform angioplasty is inappropriate and should be discarded. discouraged. At time, it could be justifiable and appropriate, and in many occasions, it's a powerful imposition by the clinical setting, and at time, it's a life-saving and necessity and inevitable, and sometimes it's a compelling, totally enforced view. And I'll give you some cases that will tell you, how that is being implemented. This is a 70-year-old diabetic, stable, positive exercise, triple vessel disease, moderate LV, that, as you can see, the evidence here is unquestionable. This patient should go for bypass surgery because it's an acceptable risk and complex situation. Then we look at this lady, 81-year-old lady, hypertension, raised BMI, non-diabetic, ex-smoker, limiting angina, positive exercise tolerance test despite optimum medical therapy. And she has this angiography, which showing severe, complex bifurcation lesion and good targets. And one could argue that this patient should have bypass surgery. And in fact, that's what happened. We presented this patient for a heart team, and the discussion of the heart team suggested that PCI is the preferred option, and PCI could be an alternative because it's an intermediate score. She left the cath lab, went back to the ward, met the cardiac surgeon, and the family and the patient decided to have a surgical turn down from their side. Experienced team met with the lady, looked at the outcome and said we can, and actually there is also a ceiling of care. Should complication happen, this patient should be resuscitated and go for emergency surgery. And what did we decide? Complex lesion, double wire, NC balloon predilatation, IVUS guided, and calcium modification with lithotripsy and upfront 2 stents. Here is a quick predilatation to the circ, but it's still not working even after skull balloon dilatation, lithotripsy, and Scoflex to the LAD. Without going into details, Kilot and POT, as you can see summarized here, dilate the circ, stent the LAD, and then POT and kissing balloon, and then you get a very good results. And the learning point from me in this case is the left main PCI justifiable and appropriate, but why? Because the patient was clinically stable, so time for heart team discussion. You don't just follow on, you have to pause. And the period of pausing give a reflection for the patient and the family and the entire team to have a shared decision between the surgeon, cardiologist, and the patient and family. Also for cath lab team to prepare, the nurses, the physiologist, everybody knows what's happening, prepare absolutely intravascular imaging and calcium modification devices, and agree ceiling of care so everybody knows what to do, and this is very important. Second case, it is a 75-year-old ex-smoker, retired joiner, have TIA, chronic kidney disease, and lives with wife and a bit assisted mobility, and presented in September 2021. Just a reminder, this is the height of COVID, this is a lockdown. So he presented with heart failure, ejection fraction 30%, and prior to that he had limiting exertional breathlessness. That's what was his ECG, ischemic with LVH as well, and we do the angiogram in October and find bifurcation, severe LAD lesion, and also, as you can see, collaterals to the right coronary artery. Appropriately, after heart team discussion, we referred this patient for consideration, and he was accepted for bypass surgery. One could argue, why is the long wait? The long wait is clearly logistics and inability to admit patient to hospital during the height of COVID pandemic. He was readmitted to hospital with troponin-positive acute coronary syndrome and further ischemic ECG changes. So the landscape has changed dramatically from a stable patient with heart failure into an intractable coronary, recurrent angina with acute coronary syndrome, severe complex triple vessel DD, deteriorating severe LV dysfunction, and you can see carotid artery disease and chronic artery disease made the surgeons quite reluctant to operate. In fact, he was surgically turned down in view of prohibitively high-risk operative risk. And that's what we did: up front intra-aortic balloon pump, 2 drug-eluting stent, IVAS guidance, and excellent results at the end. Balloon pump removed in 48 hours, in 24 hours, and the patient went home within 48 hours with appropriate medical therapy. To me, the most important part is the learning, why this case was performed. It's a powerful imposition on the decision-making. Deteriorating clinical condition may force change in decision. He was elective, then became unstable. Balancing the risk to benefit. This is medicine, balancing the risk to benefit. And also reconciling the realistic medicine, reconciling the expectation. What we sometimes have to be open and honest with patient and family is tampering their expectations, explaining to them why one might be preferred over the others, and the risk of the procedure, IVAS guidance modification, and of course the need for hemodynamic support are all equally important matters. This is another case which shows you the complexity of decision-making. 71-year-old male with this background, renal CA, while waiting to be seen in a clinic for his renal problem, he had a VF arrest. He was promptly resuscitated, and his ECG, as you can see, massive anterior ST elevation, and therefore he was transferred to our center for emergency coronary angiography. In the cath lab, that was his ECG, complete normalization of the changes, pain-free. He was hemodynamically stable and completely wide awake, and therefore the cardiac rhythm was very stable. Proceeded to angiography, and as you can see, a very complex trifurcation left main stem calcified lesion. And in view of the normalization of the ECG changes, pain-free, normal distal flow, the team appropriately paused and said, this is far complex. And this is also a credit to the team that we work with. They realize what is their skill set and what's their experience. And they marry that to the clinical situation, and they decided to appropriately stop and consult with others. So it was appropriate, pain-free, stable, not for immediate PCI, heart team discussion, accepted the patient for bypass surgery. Ticagrelor was stopped as per routine. You've heard about the bleeding risk of these things. And then he went to ITU, and the landscape once again changed completely. So ongoing arrhythmias, recurrent VF, congestive cardiac failure, rising support, inotropic support, and amiodarone is required. And the surgeons came over to ITU, said, under no circumstances we can operate now, as this is the patient would be considered surgical turn down. So what we do, we implant an ECMO, which is for hemodynamic support, and we go from the right radial approach, very heavily calcified lesion, as you can see from IVAS. We use lesion modification with rotational atherectomy, and thereafter you get very, very good results. But good angiographic results, very good angiographic results. Let us look at what happened to this patient. He was weaned off of hemodynamic support in 48 hours. His left ventricular function has improved, but his required prolonged recovery with tracheostomy. He was very slow to recover with swallowing issues, memory issues, mobility issues, and he was not discharged home after 2 months in hospital. 2 months in hospital. He was discharged to a rehabilitation center. And sadly, 3 months, so 5 months of agony for the family before this patient dies. And we can discuss the merit of percutaneous intervention here. So what is my learning point here? Unstable clinical condition will always impose dynamic decision-making. The decision that you did yesterday might not stand the following week. Double consultant scrubbing, shared decision, and moral support. This is really important. This gentleman was the grandfather of a trainee in our hospital, and therefore, just to have the moral support of knowing that you're working with a VIP in your part of the world, but double consultant scrubbing, sharing ideas, not just pushing wires and stents. Consultant anesthetist, we've heard that, the procedural IVAS guidance, lesion modification. One very important point, don't think that opening up the artery will result in immediate recovery. There is always the slow recovery to think of. The final case for me is this lady, or this male, 75, chest pain, previous MI, came in as an acute emergency, globally ischemic EGZ and complex PCI. And what we did, we started to look at what we can do. Should we stop? Should we stop? Different than the previous case. So the decision among cardiologists and cardiac surgeons, just try to do something to help PCI because the patient is dying in front of us. We do a PCI, just wires, and once you put a balloon to dilate, immediately VF arrest, intractable, and therefore we rely on external chest compression with this device here to allow us to complete the procedure, and the procedure was successfully performed, and the outcome was great in this particular situation. And this is where the decision, you really do not have any time to reflect, and you have to go with your instinct and the ability of team support. Chairman, ladies and gentlemen, I can tell you that coronary bypass grafting from personal experience for stable patients with severe complex left main stem, particularly with multivessel coronary disease, is the preferred option, particularly with diabetic and LV dysfunction. Operative risk of bypass in the elderly patient with multimorbidity may be prohibitively high with prolonged recovery. Remember, it's not the survival, it's the recovery, and uncertain long-term benefit. Complex high-risk clinically indicated PCR chip in select group of patients with complex left main disease may be appropriate and preferable to bypass surgery. Heart team, shared decision-making, meticulous preparation, and high-volume experienced team are all essential factors when considering complex PCI. Thank you.
Dr. Hany, great, and I like the ceiling treatment, which really is when the medical team provide the appropriate, best evidence aligned with the patient and family's values, wishes, and beliefs. So that's great. I hope we all do that. Any comments from the panelists?
Yeah.
Please.
Thank you very much. I think this really summed it up for me. Showing how the heart team operates for the benefit of the patient, not for the benefit of anybody else. Just a quick question. PCI operators, as you've shown in several of your cases, will take the sickest of the patients, the surgical turndowns, the ones who are dying on admission, with very complex left main, without a heart team discussion, because there's no time, as you showed in the last case, and will come up quite, repeatedly, consistently, with excellent results. And this is what actually led a lot of cardiologists to fight for the left main cases, because they think the surgeons are cherry picking. They're taking I don't agree, but that is the argument, is when we as interventional cardiologists are taking the sickest patients that the surgeons don't even want to look at, and, hopefully sending them home doing quite well. So when it comes to the easier patients where we can sit and plan, of course, surgery is better on the long term, but the morbidity of the sternotomy is actually feared by many of those elderly patients. So, do you think that based on the current data, we as interventional cardiologists should still try and argue for PCI in less sick patients who, I'm not talking about the syntax 50 score, I'm talking about reasonable patients. Or should we just keep on taking those surgical turndowns and leaving the easier patients for the surgeons?
Yeah. It's a very important point. So basically, I'll tell you what our practice is. We really contributed a lot to all the evidence gathering for left main stem. And we would not have done cases for left main stem out of the protocol. And this is the value of participating in research. You can do what you can't do in clinical practice as long as you are, through the ethical committee, doing a research conducted protocol. But back to your specific question, we really do every case with left main stem stable. Case with left main has to leave the cath lab and go for a heart team. Yes. And absolutely pros and cons are addressed. But we are learning that patient preference and patient choice is very important and has to be respected, provided the patient is informed properly. Because I can tell you, sometimes the surgeons would go, or the intervention cardiologists would go, and say not entirely the fair situation. Yeah. So I think the evidence to us all, as it's been seen here, there is equivalence for left main stem and bypass surgery in simpler lesions, particularly in low-risk cases, and we should continue to do that.
Thank you.
Thank you very much, Professor Hany Eteiba, for being with us and for the nice, elegant presentation and for your really nice comment on us and your contribution to our meeting. Thank you very much.
You have 5 minutes. You owe me 5 minutes.
I would like to conclude to thank our moderator, Dr. Abdullah Shahab, dear panelists, Dr. Abdul Majid Zbeidi, Dr. Ahmed Al-Gundi, Dr. Hany Raghi, thank you for being with us. Now I will call for Dr. Faisal Al-Goufi and Dr. Wa'il Al-Kashkari, and also our speaker, Dr. Abdurrahman Al-Qahtani, to lead the next session.